Hello, everyone. I am Claire Stile with ACC Minnesota, and thank you all for joining us for tonight's lecture, The History and Current Use of IV Antiplatelet Agents. Many thanks to Dr. Mina Sali, Cardiology Fellow at Hennepin Healthcare, for tonight's presentation. But before we begin, I'd just like to share two upcoming events that ACC Minnesota has coming up. Our next Fit Lecture Series talk is on Tuesday, April 11th by Joe Jensen, Dr. Joe Jensen. And if you know anyone who is maybe a little earlier in their career, we have an event. Our Women in Cardiology section has an in-person event at Ladonia Brewery on April 15th for medical trainees interested in learning more about the field of cardiology. So I'll post links to those things in the chat. I'd love it if you could share with anyone you know who might be interested. Great. Yeah, thank you. And if you have any questions about that, feel free to ask during the chat today. But without further ado, I'll pass it over to Dr. Asali, who's going to introduce his talk.
Absolutely. Well, thank you, Claire, and thanks for everyone attending online for this lecture. So this lecture, basically feel free to put questions in the chat box, and we can address at the end if there's any questions that may come up during the presentation. I'm gonna share my slides shortly here. 1 second. Let's see. Okay, so again, this talk gonna be about intravenous platelets, and for me, coming into fellowship, this topic was did not have so much experience during my residency, and it's a little bit confusing as you will see some patients on it, some patients don't need to be, so it's variable use of such intravenous agents. And so my question's always been, what's the role for them? Should we use them? Should we not? During my lectures, this lecture basically, I will try to go through the data over the last 20 years or so. Just briefly to go through the trials and how this whole topic developed throughout the years. So basically the issues that makes this topic a little bit difficult, like just like anything else in cardiology, is the fast pace of development of whatever we've been doing over the last several years. So you start conducting a trial, and then you will have a new agent coming up that people may or patients may not be on it, and then your trial will not be up to date. So and what I mean about that, especially about this, is you have the bare metal stents. First of all, you start with balloon angioplasty in the 90s, and you start having the bare metal stents coming along, and then you start having your first generation drug-eluting stent, which has higher rate of thrombosis, and you do your trials with these intravenous antiplatelet agents about all the major cardiovascular events, including stroke, MI, death, and you get your results. But then you'll have the second, drug-eluting stents, second generation, and are these agents absolute now? Should we follow along using them or not? Now we have those newer drug-eluting stents. So without further ado, so if there is one thing to learn about this lecture, is gonna be my last few slides. I'm gonna go through what the ACC, basically the recommendations, guidelines, and level of evidence for these agents and their use in the current era, like these days, and should we use them and when. And but before I reach that, which is my final few slides, that's gonna be where I'm gonna touch base on that part. Let's go and basically what's things we're gonna go through. We're gonna discuss the glycoprotein 2B3A inhibitors and their dosing. How did that develop? Limitations, as I just mentioned in at the beginning of my slides, in my introduction. Limitations of these trials, and what's their role? The role in these medications in ACS, and I will briefly touch on cangrelor, an intravenous P2Y12 inhibitor that's also can be used in certain circumstances. So I will start my lecture with, and actually a case here that I've actually encountered at Hennepin County Hospital, where we have this patient. It's a real life scenario, and that's gonna be relevant to this talk. So she's 61-year-old, presented with shortness of breath to EMS, some chest pain, low blood pressure, ended up being intubated, and the AKG shows this. So you'll see clear current of injury and some almost AV dissociation and slow heart rate. We ended up doing a transvenous pacing to support her hemodynamically. She received aspirin ticagrelor. Her platelets on presentation were 224K. She was given bivalirudin bolus, and a drip was done. And bivalirudin bolus by itself, it's Angiomax, and it's an alternative agent that can be used as anticoagulation. It's not the widely used one, which is heparin. There is interesting, actually, newer study from China saying that bivalirudin is as safe as heparin. Its use has become, it's not the fair, it's a class 2B, it's class 2A, sorry, and heparin is the one just because increased risk of catheter thrombus, which this new trial that's done, published in China, saying, okay, this is not the case. There's not much increased risk of catheter thrombosis. But anyhow, that's not what we're going to focus on. So this patient was placed on that. This is the angiogram. Left to your left is the initial before intervention, and you can see with your JR catheter, you'll have a proximal occlusion of the RCA, and after that, you'll have your PCI and TIMI3 flow. So great results, angiographic results. She did not need further transcutaneous pacing, and after the procedure, or after her coronary angiogram, she got complete heart block. Actually, she was intubated, so it's difficult to tell any symptoms. All we got here is a AKG finding consistent with complete heart block. So the interventionist took her back to the cath lab. There was suspicion there's acute closure, and sure enough, RCA thrombus, got aspirated, and aspiration catheter. She got 2 drug-eluting stents. Good position of the stent, good placement, confirmed with intracoronary imaging with IVUS. And so here you will have the eptifibatide comes to role, integralin, which is that's what we're going to talk about today. It's IV glycoprotein 2B3A inhibitors, and that was started with this dosing. You give a bolus, you start on a drip, and then a second bolus in 10 minutes with heparin, and subsequently she's on the drip. Some images from the angiogram, and in few hours, platelets CBC checked, platelets 36K. That was confirmed to be true. Thrombocytopenia, drip was stopped, and I will talk more about that part shortly. Again, current of injury, she was taken back to the cath lab, and again, TEMI2 flow, layered clot across the RCA. Thrombectomy was done. She was placed on heparin with no glycoprotein 2B3A inhibitors, and she did not need further stenting. So we can see in all of us encounter such cases where, okay, so the patient is, in most of the cases, I would say, at least from my limited time I spent during my fellowship in the cath lab, okay, STEMI comes in, you treat, stent placement, patients are okay, they're just doing fine. But it's those cases where, okay, do we have something else that we can use? Should we, is there anything else we can do to make things better? Assuming that angiographic intervention or PCI in these cases were optimum, image guided, and good stent apposition with good angiographic results. What else can we do for these patients with high risk recurrent thrombosis and poor coronary flow, having recurrent episodes? So here I will go through basically just briefly. I promise I will not spend so much time on this, just to talk about the biology of platelets function, just to remind ourselves how do these medications work, and basically understanding this, it will help us understand how basically the mechanism of action. So if we can take a look here, so we all know ACS start with a plaque rupture. You get platelet activations. So intimal injury, you get exposure for that collagen. You get the platelets. They get adhesions of the platelets to the matrix. They get to the von Willebrand factors, and that's helped with the glycoprotein 1B. So this is a nice picture, and we can see how the fibrinogen plays an important role in connecting between platelets, aggregation, but it's all about activating those glycoprotein 2B3A on the surface of the platelet. So there is these two images, but before, so in general, most potent activator for platelets is thrombin. Okay, and there is ADB receptors on the platelet, and that's where our drugs act. Basically, our Plavix, prasugrel, ticagrelor, P2Y12 inhibitors. So let's take a look. Let's take a look quickly at this slide. Here is our ADB. Okay, it's the surface of the platelets. You get that activated, and then you have increased activation of platelets, change in the shape, that's increase in the aggregation of these platelets. ADB is a site for mechanism of action of many of our commonly used drugs in acute coronary syndrome and ischemic heart disease. Those are including clopidogrel, prasugrel, ticagrelor, and ticlopidine. So, but if you notice, it's an indirect way of inhibiting those platelet aggregation. But when you look at the glycoprotein 2B3A receptors, those are, if you inhibit here, you inhibit the aggregation. It doesn't matter so much what happens to other receptors. They're all secondary if you inhibit the end product. So we can take a look at this nice picture summarizing all, or at least most of our drugs we use in our patients in different obviously different mechanism of action, some of them as antiplatelets, some of them in anticoagulation, like working on factor 10, but we'll not focus on any of those and focus more on our topic of today, which is glycoprotein 2b3 inhibitors. And it works directly on this, which is, so fibrinogen connect 2 molecule of glycoprotein 2b3 inhibitor and help making this platelet aggregation. If you block it here, you end the cycle. You block the secondary, you'll have a weaker effect, antiplatelets effect. So this is what we want to focus on, this part of the image. Okay, so that's why it's more effective. So in terms of percentage wise, when you use those IV or intravenous glycoprotein 2b3 inhibitors, I will refer them for short glycoprotein inhibitors. When you use them, you achieve almost 80-90% platelet inhibition. So compared to the just 10% when you used with aspirin or achieved with aspirin, but still you get almost 50% with the P2Y12 inhibitor. So they are pretty good agents, and we all know how much they are in a way quickly replacing, but that's a different talk, replacing aspirin and how effective they are even as a monotherapy. But if you want your absolute like most inhibition, you will get it out of IV glycoprotein inhibitors. So there was great interest, especially in the late 90s, early 2000s, about these agents. So what are these agents, and are they available here? So 2 out of the 3 are. So abciximab, no longer available, I believe in 2019 or 2018, I believe 2019 was taken. It's no longer available in the US. The other 2 are, so eptifibatide, integralin that is, and tirofiban, aggrastat. So those 2 agents are still available. They have their special dosing, which we will talk about. So, okay, this is a busy slide. It just talks about all the trials that looked at these agents. Let's take it one at a time and look at integrin, eptifibatide. So what is eptifibatide? It's a highly specific agent that can block glycoprotein receptors, sorry. Low affinity, it rapidly dissociates from the receptors. That's why it's a reversible. It doesn't last long. The platelet inhibition effect doesn't last long. It's non-immunogenic. So we're not talking about abciximab here. It's not a immune globulin. So it is, because it's a smaller molecule, it's non-immunogenic. Half-life is just 1 hour. And we should remember patients with kidney dysfunction can have higher levels of this medication just because it's renally cleared. That's 50% renally cleared. So the dosage should be adjusted. So you will achieve almost you will complete inhibition of ATP, induced platelet aggregation, within 10 to 15 minutes of the bolus infusion. So very, very effective agent. So after you stop your infusion, in a couple of hours, 2 to 4 hours, you have everything reversed. So this is where the thrombocytopenia piece comes in. So we need to keep in mind with these agents, very low risk, 1 to 2% in general. With these agents, there is a risk of thrombocytopenia. So again, it has eptifibatide. It has this, or Angiomax. It has this unique dosing. So you start with a bolus infusion. 10 minutes later, you do a second dose, second bolus, and it's all. This whole dosing came about with a trial that we will talk about shortly. So in the IMPACT-2 trial, they basically distributed treatment arms, as you can see, different dosage regimen. There's no double bolus here, bolus and an infusion. And everyone received aspirin and heparin. What they noted is there is, in terms of the outcomes, you can see death and MI composite primary endpoints based on the dosage. So the trial was not did not show the results we were hoping for in terms of the effect. So there comes after that VERSUT trial that it did not include STEMI patients. It looked at same primary endpoints. We have this, they tried a different dosing from the active hepatide. It noticed that 1.5% absolute reduction in the frequency of the composite endpoint was reached by 4 days and maintained for 30 days. So good. So we got some results with the newer dosing. So then comes the spread trial. And this one tried this new dosing. It's basically said, okay, let's give the patients 2 180 boluses, 10 minutes apart, and then follow that with the infusion. And primary outcomes, great. They found quite significant difference in the primary outcomes between the both arms. All right, so 1 second. Let me pull this slide. Okay, so here, so with this trial basically showed that for patients undergoing PCI, you get better results when you do more platelets inhibition. It is worth mentioning that this is pre-P2Y12 inhibitors era. So yes, we learned if you achieve better platelet inhibition, you get better results. This is obvious from these trials. Okay, you get, and the SPREAD trial showed the best results. That's why this dosing is what we follow these days for the active hepatide. And but again, this is prior to the Plavix and all these newer agents. So then want to touch base briefly about tirofiban. Okay, so tirofiban is highly specific, unlikely to induce immune response, just like eptifibatide, short half-life, just like eptifibatide as well. You achieve great inhibition of ATP-induced platelet aggregation. It is not double bolus, it's a bolus and followed by an infusion. Again, in 2 to 4 hours or 4 hours, most of your effect from the platelet inhibition is gone, and you need to be careful dosing these medications with renally diseased patients, which isn't a lot of our patients are. So CKD patients, you need to be careful, increased risk of bleeding. So you will also, one thing to remember with these agents, you have the thrombocytopenia. Remember 1 to 2%. 1 to 2% of patients can develop thrombocytopenia. Okay. So when we take a look at these agents with PCI, okay, what's their role? So early trials studied this in the area of balloon angioplasty and perimeter stents, and that's the major limitations. They're not consistently contain P2Y12 inhibitors as well. So they showed reduction in primary outcomes, not surprisingly, given that we did not have as good medical therapy back then. So, but the majority of event reductions were peri-procedural, from the prevention of peri-procedural MI. But what we learned throughout most of these trials, if there is a benefit, it's more noted on coronary intervention. It's not surface vein intervention. So analysis did not show much of a benefit on these agents. So remember, and again, I will touch base on that at the end of my presentation, these agents majorly used in coronary interventions, not with grafts, because that's where some of the evidence found for benefits in the trials, not in SVG grafts. So there comes a couple of trials that examined apixaban. It's no longer available, but it's the same family of medication, similar to the other two. These two trials, ISR React 1 and 2, and it shows if they risk stratify those patients according to troponin, patients with a troponin positive who undergoing PCI, apixaban group did better. So troponin negative, not much of a difference. Okay. So low risk patients, not much of a benefit. Higher risk or troponin positive, you will have 25 risk reduction. The benefit again was majorly seen in troponin positive patients. Surprisingly, no major difference with bleeding in those trials. So given this observed patients with ACS, basically troponin positive patients undergoing early invasive, question rose at that time, should we give these medications upstream just before the patients goes to the cath lab, or should we give them downstream? Is there a difference? Can we improve basically results and primary outcomes and MACE? So this is what early ACS trial tried to answer. And patients were randomized to active hepatitis early, 12 hours or more. For anyone planned for PCI, they will get their active hepatide or glycoprotein inhibitors 12 hours early, or delayed group, which delayed group meaning at the time of the PCI. So what we noted, it did not make much of a difference. The only difference it made people bleed more. So, but there was a trend toward benefit. So, and that was seen in a meta-analysis. So, but the issue here, okay, you get 11% reduction in 30 days death MI, but you are getting 23% higher risk of major bleeding. So as all of you know, it's always that balance of, okay, thrombosis risk, bleeding risk. How much can we do where we balance that? So you get to the point where you have 23% bleeding, and then the question becomes, should we even do upstream therapy? And that's what this trial basically tried to answer. So based on that, the meta-analysis, the acuity trial, all showed modest reduction in ischemia and marked increase in bleeding. So hence, after that, we were able to say, okay, maybe that's not a good idea. Let's not do upstream early treatment or early before going to the cath lab using these agents. So, all right, so then comes another question. And what this question was, can these agents be used as a bridge for high-risk ACS patients and who just show up and they're not on P2Y12 inhibitors? Those agents, as you know, it takes 2 to 3 hours for them to kick in. okay, newer agents do better, like ticagrelor or prasugrel. Plavix may take slightly longer for it to kick in full action. So you'll have that period of 2 to 3 hours where you don't have the full effect of these newer agents, P2Y12. So can we use those glycoprotein inhibitors as a bridge until we have those patients on the proper therapy and going? So that's what the trial, facilitation through agrostat or cangrelor bolus and infusion over prasugrel, tried to answer. Fabulous, faster trial. So you get these STEMI patients, you randomize them, and what's interesting about this trial, it did not try to look at primary endpoints, the usual MACE. Most of trials looked at it, tried to answer platelet inhibition. How much platelet inhibition can you achieve at 30 minutes? And this is how the trial were designed. So you have a STEMI patients, you want to achieve platelet inhibition. Should you use prasugrel, tirofiban, cangrelor? You get randomized to either, and then you'll take a look at the results. And here what we found, basically. So, excuse me, 1 second. So just looking at this chart, we can see that tirofiban was superior in inhibition of platelet aggregation compared to with cangrelor, but both cangrelor and tirofiban were superior to the chewed or whole prasugrel. And you see this point where you'll have your platelet inhibition, it's 2 hours. Take a look. So prasugrel, in general, chewed or integral, you will have the antiplatelet effect measured. When you measure it here, okay, 30 minutes after, okay, this still did not kick in. You look at cangrelor, it's here. You have the tirofiban, it's the strongest out of the three. Yes, we said you get the glycoprotein inhibitors, they give you the maximum 90-95% inhibition of those platelets. You take a look at cangrelor, which is an intravenous P2Y12 inhibitor, and you get much better results compared to the oral route. But just oral routes, it kicks in. It just takes a couple of hours, and then you'll have your inhibition. So this is what this trial showed. So but to come back to this point about introduction of the whole P2Y12 inhibitor and the use of these agents. So after introduction of these inhibitors, several trials which were run, including BRAVE3, FINESSE, showed not much of a benefit now, and you'll have increased risk of bleeding. You're okay going with our choice of P2Y12. What we do nowadays, you will be fine. Just do P2Y12 inhibitors. You'll find, because if you use those agents, you're not getting much out of it. You're not getting benefit out of it. You're actually increasing risk of bleeding. So that's what the BRAVE3 and FINESSE. So FINESSE took a look at, can we facilitate the interventions with the STEMI patients if we do apixaban, use some thrombolytic therapy, half dose, or apixaban alone, or placebo. So you give a placebo for these patients who is undergoing PCI, and you take a look at the primary endpoint, and you take a look at 90. So obviously, you consider the first two arms facilitated approach, and the third one, which is the regular approach, you don't use any agents, no intravenous P2Y12 inhibitors or thrombolytics or anything like that. So, okay, so did not find a difference. So facilitated like expected, showed an increased risk of bleeding, and you don't have much difference risk of complications. The BRAVE 3 came along and tried to understand the value of abciximab use in acute MI after high loading dose of Plavix pre-treatment. So what they studied basically upstream use of abciximab plus using Plavix. Also, what they used technetium. They followed these patients up. They wanted to see, are we getting better reduction in infarct size if we use these agents, upstream use of abciximab or P2Y12 inhibitor? They did not find that in this study. So then the question came along, okay, so we are getting some benefits, but or maybe we are, or maybe we're not getting enough benefit because we're not using those agents the right way. So does it make any difference if we use intracoronary versus IV? Also, this study, IDA-STEMI, failed to show a difference when you use ICE intracoronary or intravenous. So this is the design of this study. And when you take a look, you will have you'll have pooled analysis from different 5 randomized trial. Okay, you see some difference, okay, but it's just you see this point, is it statistically significant or not? So okay, there's a trend toward benefit, but yeah. So then comes the infused AMI trying to answer this question, and it studied it differently. If we use intracoronary abciximab and also studied the manual aspiration. So take a look at this. So what they did, they took 452 patients, anterior STEMI. They randomized. So aspiration, no aspiration. And then after that, 1-to-1, are we using abciximab or no abciximab? And took a look at the primary endpoint. So here we look at the results. Aspiration, not much difference. Whether you do that or you didn't do aspiration thrombectomy, or you're getting similar results. You will have some, but when you look at intracoronary versus no intracoronary, you have benefit here in the infarct sites. And that's done by follow-up, 30 days follow-up of cardiac MRI. So a little bit different from the prior trial, right? So infused AMI did not show that. So, and also TABA's trial showed some unequivocal mortality benefit at 1 year with manual aspiration. So we see those couple of trials negating each other, they're not the same results. So there comes a question about how many of those patients underwent stenting in after thrombectomy in the infused trial. So maybe that's why we did not get as much results from thrombectomy, because TABAS showed some benefit. So, but what we can see also in the IDA-STEMI did not show much benefit on intracoronary versus intravenous. Then comes some argument, maybe the distal delivery of the P2Y12 inhibitor with a microcatheter that's done in the infuse, but not in the IDA-STEMI, could have achieved the better inhibition, therefore improve the infarct size. So we see the both coins here, right? So you have TABA's trial saying, okay, there is benefit, but then infused AMI did not show benefit for aspiration, thrombectomy. And then you'll see the infused AMI saying intracoronary delivery of those agents is helpful, but then the IDA-STEMI didn't. So the guidelines came along and said, okay, so it's maybe reasonable, class 2B, so it's not a strong evidence here. So there's contradictions, it's difficult to tell what's the right way of doing it, or what's the right approach here. So it is reasonable, it may be reasonable to administer those agents in the pre-cath lab setting, ambulance ED to patients with STEMI who are undergoing primary PCI. Okay. It's so many trials, so much discussions about them. what we want to focus or what we want to learn out of all of that is, okay, what's the primary problem with these agents? Patients tend to bleed. Several trials showed that. Especially when you have when you have the clotting time or the heparin dose is too high, you increase risk of bleeding. Bear in mind, a lot of those trials also done in the era where femoral approach was the predominant approach. So that makes things worse. So bleeding, you will have more risk of complications. You don't have the radial approach as much, especially in the early 2000s. So whether the bleeding risk can be mitigated with transradial, short infusion time, that's something that was actually studied with the brief BCI. Should we do a shorter duration and 2 hours versus 18 hours? And yes, showed that, okay, you do shorter duration, not much difference. You'll actually lower rates of bleeding and no difference in ischemic endpoints. So maybe we shouldn't give the infusion for so long after. But in general, those bleeding events, they happen majorly hollow organs. They're not solid organs bleeding, GI, GU. Severe thrombocytopenia in general, just keep in mind 1 to 2%. Keep in mind CKD patients or renal dysfunction are at higher risk. And this is the guidelines in ACS, and this is what I want to emphasize out of this whole lecture about glycoprotein inhibitors. What's the guidelines are saying? Class 2A, you have an ACS patient undergoing BCI, you have one of those 3 things: large thrombus burden, no reflow, or slow flow. So you have these 3 conditions during PCI with ACS patients. It may be reasonable to reach out for those agents. So you can notice that it is majorly used in the cath lab, these agents. It's not an upstream, majorly it is a cath lab medications you can pull when things are not going right. The patient is so much thrombus, you don't have no reflow or slow flow, TEMI 2, TEMI 1. Maybe those agents can help. They are very, very effective antiplatelet agents. The major downside, many trials did not show so much benefit, especially with newer agents we have, but we know they are very effective. We know they have great platelet inhibition. So that's why the guidelines say, okay, it may be reasonable to use, and especially with these patients population. So briefly, in the last 10 minutes here, I'm going to talk about cangrelor, and then just summarize the perils about the things we want to keep in mind. So cangrelor, IV B2Y12 inhibitor. It is onset of action is quite rapid, 2 minutes. It goes away in 1 hour. You don't have to worry about renal adjustment. It is non-thienoperidines, so meaning thienoperidines like clopidogrel, prasugrel, those 2, the cangrelor will block their receptors. They cannot function. They will not function. So you can't give them at the same time. So ticagrelor, you're fine. You have a drip going, you can give your patient ticagrelor. But for clopidogrel and prasugrel, you have to wait until the drip is, you stop the drip, and then you can give those agents. So what is FDA approved use and indication for cangrelor during PCI, and how we came along? Basically, what the dose indication, you give a bolus and then you infuse for 2 hours or PCI duration, whichever is longer. And this is the 3 trials that's looked at this: Champion, PCI, Platform, and Phoenix. There is some of them equivocal and some of them positive. We'll quickly go through them. And then bridging prior to cardiac surgery is a very interesting concept and very interesting situation where we see those cases like here and there where you want to ask yourself what to do, and we'll go quickly at this trial as well. So infuse after you still continue the B2Y12. I will show you actually the trial, and there is a very nice graph that summarizes this trial. So what's the guideline saying? 2B. So class 2B, not very strong evidence in support of this. So in patients getting PCI, take a note of this. They are P2Y12 inhibitor naive. They're not on these agents. It is reasonable to start IV cangrelor to reduce ischemic events. It is reasonable, especially if someone cannot take PO medications. Intubated, undergoing PCI, say STEMI, and then for whatever reason, you don't have a PO, OG tube, you can't give P2Y12 inhibitors, PO, you want an IV agent, you can use cangrelor. This is the major, I would say, indications or use, beside the bridging, which we will talk about. So 3 trials, Champion BCI, Champion Platform, and Phoenix looked at this. And what they basically, when they randomized the patients, did not find a difference in terms of using those agents. It was not superior to clopidogrel at 48 hours. And if you look quickly, everyone received the Plavix, but question, if you add cangrelor to this as a something until you have the Plavix effect kick in, are you gonna get the different? No, you did not. In Champion BCI did not show that. So you'll have the Champion Platform, and primary endpoints was not met, enrollment was stopped, but they noticed some lower risk of stent thrombosis in the use of P2Y12. Okay, and then comes the last one, Champion Phoenix, which showed there is a benefit. People who got that will have less events. Basically, event rate is lower in patients on cangrelor. So you'll have all these different. So these 3 trials, 2 of them negative or equivocal, and the third one was positive. Like, there's a benefit. That's why it's a class 2B. Quickly to touch base on the bridge. What they did in the bridge? Okay, you got a patient, they come to you, they got a stent, they need in the STEMI, say, and then they got a stent, but they need cabbage, right? So they got, say, RCA STEMI, put a stent, and then they have a left main LAD cert, they need a cabbage, but how can you stop the B2Y12 when you just have a fresh stent? So what they did, let's stop prasugrel 7 days before, or 5 days if clopidogrel or Prolenta. You start the cangrelor 2 days after, or 3 days prior to the surgery. You stop it a few hours before, you start it a few hours after. The only issue here, they study the limitation about this trial. They did not look at ischemic events. They just looked at the P2Y12 reactivity unit. How much effective antiplatelet agent did we achieve using this strategy? And it's great. We achieved almost 99% compared to the people who got placebo. No difference in the bleeding. So, quickly, let's summarize the pills. What should we do with these agents? Patients already on clopidogrel and aspirin, do not use glycoprotein 2B3A, especially do not routinely use. You have increased risk of bleeding, not much of a difference in events. They have very strong antiplatelet effects. Only high thrombotic burdens patient. Optimal duration, the shorter the better. You don't have to have them be on a long infusion, just few hours after the BCI, 2 to 4 hours maximum. Risk of major bleeding is worse with elderly women and patients with renal insufficiency. Keep in mind the thrombocytopenia, 1 to 2%. Patients with the BCI, you have a large thrombus burden, low reflow, no reflow, or slow reflow, or you have ongoing ischemia, as we said, and intraprocedural bailout. Okay, reach to your pocket, you have these agents. Okay, you can use them. Weak evidence, though. Weak evidence. Timing of administration, you don't have to do upstream at the time of your PCI. You don't have to do upstream. You have increased risk of bleeding and not much difference in outcomes. Cangrelor, keep it in mind when you have those patients. You're doing PCI. They're not on P2Y12. You cannot administer it for whatever reason, acutely sick in cardiogenic shock or whatnot. You can use them as a bridge. And that's what also the bridge tried to study about patients. You got a stent and you want to take them to cabbage a few days, stop the B2Y12 inhibitor, and then you bridge them with Cangrelor. And you stop it a few hours before and we start a few hours after. You don't have difference in bleeding. It was not studied, was not powered to study events outcome. Did it make any difference in terms of MACE? It did, though, achieve a great platelet inhibition. That's we could tell from that trial. So here are basically, this is the summary. It was what we can tell from all these slides and all these trials, just my experience going through this. Okay, they're there, these agents. You hear them being used in the cath lab majorly. That's where you hear them most. You rarely see them on the outside the cath lab being used. It's good to have an idea where the data came from. A lot of it is newer agent, P2Y12 new. We have good agent, good platelet inhibitions. They're safe. They get great results. You have less events with them without so much risking higher bleeding. You have very few cases you still may benefit from using these agents, and they are majorly used in the cath lab. So with that, thank you everyone for attending this. These are my references, I hope. And if any questions, I'm happy to answer. And thank you so much.
Yes, thank you so much, Dr. Scully. If you do have any questions, please put them in the chat now. Otherwise, we will sign off. Let's see, so we'll just give it 1 second. Okay, I don't see any questions coming in, so I think we can end for the night. Thank you again, Dr. Scully, for your time. And we hope to see you all at the next one.
Thank you so much. Thank you. Bye-bye.